So the aims, next slide please, the aims of the webinar are to outline mental health measures and data available in the CLS cohorts, give you some information on how to access the mental health data, and highlight available resources. Pravitha will illustrate some of the seminal work in mental health using the CLS cohorts and highlight the types of mental health research that can be done using birth cohorts. So a bit about CLS, as some of you don't know very much about the cohort. So the Centre for Longitudinal Studies is home to 4 national longitudinal cohort studies. There are others, but these are the main ones at the moment, which follow the lives of tens of thousands of people. And each of our 4 studies follows large, nationally representative groups of people born in a given year or years. By collecting information from the same people over time, as they live their lives, our studies are powerful resources for answering important research questions. The studies are multi-purpose and multidisciplinary and collect detailed information at different aspects of the cohort members' lives. So, for example, economic, social, and health. So moving on, the 4 cohorts we house at the Centre for Longitudinal Studies are the NCDS cohort. So they were born in 1958 in Great Britain in the same week, and the initial sample was 17,500. The second is the 1970 British cohort study, again born in the same week in Great Britain, and there are around 17,000 participants. The third is Next Steps, which is slightly different from the other 3, as the study began when they were aged 13 to 14. It was initially run by the Department for Education up to age 20. Is England only and has just under 16,000 participants. And then the third is the fourth is the Millennium Cohort Study, born in the UK from 2000 to 2002, and there are around 19,000 participants. So next slide, please. Before I explain this chart, the eagle-eyed among you will have noticed another study appear here, and this is the 1946 National Survey of Health and Development. And the reason I've included it is some of the cross-cohort research that Pravitha will talk about includes the 1946, and it was kind of a predecessor to the 58 and the 1970. So all of these studies are ongoing. This chart shows the year on the horizontal and the age on the vertical, and the dots refer to periods of data collection. So the oldest cohort we run at CLS is the NCDS, the 1958, and since then there have been 10 data collections, excluding the COVID surveys, which I'll talk about in a minute, and the last available collection was at age 55. Currently, we're in the last stages of fieldwork for the age 62 survey. The BCS 70, since 1970, there have been 9 data collection periods, the last at age 46. And again, we're in the last stages of field work there for the age 52 survey. And Next Steps, so from 2004 inclusive, data was collected every year for 7 years in total, all until they were aged 20. And the last sweep was when they were aged 25. And again, we're currently in the field for the age 32 survey. And finally, the Millennium Cohort Study, including the first data collection at 9 months, there's been 7 sweeps, the last at age 17, and the age 22 sweep is being piloted at the moment. So just to give you a brief overview of our studies. So first, the NCDS, the 1958 cohort. So in the early sweeps of the study, the main respondent were the parents. At age 16, there were rather more. The cohort members were rather more involved in the study, and they became the main respondents from age 23 onwards. And information was also collected from schools, for example, how the child behaved in school and their examination results, and from medical examinations as well. Height and weight, for example, has been collected at most sweeps, and a biomedical sweep at age 44, which included blood samples for biomarker data and to extract DNA. Cohort members also sat a variety of cognitive tests at age 7, 11 and 16, and a further set of cognitive function tests were included in the age 50 sweep. The original sample, as I said, was about 17,500, and in the last 4 sweeps since 2003, there have been over 9,000 participants in each of the sweeps. So the next cohort The BCS 70, again, in the early sweeps of the study, obviously the main respondents were the parents. At age 16, they were rather more involved, and the cohort members became the main respondents from age 26 onwards. Like in the NCDS, information was collected from schools. Cohort members also sat a variety of cognitive tests at age 5, 10, 16, and a further set of tests were included in the age 42 and 46 sweeps. In earlier life, the cohort members had medical examinations. Again, height and weight has been collected at most sweeps. The age 46 was a biomedical sweep, which included collection of blood samples for biomarkers and DNA. And they also wore an accelerometer and completed a diet diary. I can never say this, diet diary. The original sample of around 16.5, 17,000 has fallen over time. So in the last sweep, we've got just over 8,800 participants. So in next steps, the study member has completed questionnaires themselves at every sweep. Sweeps 1 to 4 included interviews with the study member's parents, and from sweep 5 onwards, it was only the study member who was interviewed. The survey data has been supplemented by linked administrative data from the National Pupil Database at Key Stage 2, so age 11, 3 age 14, and at Key Stage 4 at age 16. And more recently, higher education statistics and student loans company information has also been linked. And we've also collected an extensive range of data linked consents at age 25, and that's true of all the cohorts. So we're linking data as soon as we can to different areas. The original sample of 15,770 was boosted with a further 350 Black Caribbean and Black African pupils at sweep 4 in 2007. And at age 25, which is when we took over the survey, we decided to go back to as many as possible of the 16,000 original cases, participants who had taken part, and we managed to interview 7,700 plus, which was a considerable achievement, really, considering their age and the fact they hadn't been followed for up to 5 to 10 years. And finally, the Millennium Cohort Study. The parent was the main respondent, again, from age 9 months to 14 years. The cohort member started to give their own responses at age 7, and their contribution increased over time. At age 17, the cohort member became the main respondent. Siblings and teachers and the main respondents' partners have also taken part. Cognitive and mental health instruments, which I'll talk about later, which were age appropriate, have been measured over time, as well as, again, height and weight. Some really exciting enhancements have been included. For example, they've worn an accelerometer at age 7 and 11. Saliva was collected for both the cohort members and the biological parents, and they've completed time use diaries. The original sample was 18,500, and at age 17 now it's 10,600 odd. So in addition to the main sweeps, as I mentioned, of the studies, we've also conducted interviews during the COVID pandemic. There were 3 waves of data collection at different stages of the pandemic. So during the first national lockdown, when restrictions have been eased in early autumn, and then the third again during the third lockdown. And the surveys were completed online. And what makes the CLS COVID surveys unique from most other COVID surveys is that they are embedded in the survey and can be used with all the wealth of prospective information collected pre-pandemic to investigate outcomes during the pandemic. So you can see a vast amount of information has been collected about the cohort members across the life course. The content is multidisciplinary, as I mentioned, spans social, economic, psychological, and health. And similar information has been collected in each of the studies, as well as additional information specific to each of the cohorts. So there's information about the cohort members' parents, so including family socio-economic situation. There's details on their birth, health issues during birth, for example, while they're growing up, so the circumstances they grew up in, information about their family, schooling, transitions from education to employment, relationships and parenthood. And then measurements also taken over time that I've already mentioned. So, for example, cognition, there's also mental health, which I'll talk about, and well-being, physical measurements and health data, including biomarkers and genetics in the NCDS and MCS, and as I mentioned, our COVID-19 surveys. And other areas which are related to mental health, including diet, sleep, substance use, bullying and victimization, and much, much more. So, this is what we're here for. So we're now going to focus on the mental health data. So we're going to look at including self or others' reports of mental health problems, mental health and well-being scales, what was collected during COVID-19, linked mental health data, and what mental health data is coming in the next sweeps. And what's covered here is an overview and is not extensive, and just because it doesn't appear here doesn't mean it's not available. So the next few charts, I do apologise, they're very busy, but we've given you all the detail on the slides, and we can hopefully give you an overview of what's in the data. So we'll start by looking at reports of mental health in these cohorts. Firstly, there are different reporters. So highlighted here in the different colours. So the cohort member self-report is in orange, the parent reporting about the cohort member is in blue, the cohort member's teacher is in green, and the health visitor and nurse is in grey. And finally, in purple, the parent reporting about their own mental health. And we've tried to group what has been reported together, primarily differentiating between diagnosed by a doctor versus seen by a doctor or suffered, or say that they're suffering from a mental health problem. Across cohorts in the rows there, it doesn't mean that the exact same question was asked, but they're similar-ish. In childhood, we have reports from the health visitor, nurses on doctor's diagnosis. In the earlier cohorts, seen a doctor for depression and anxiety in the later cohorts, as well as the earlier. Also, in more recent cohorts, whether they've had a long-term illness, a mental health illness reported by the parent, and also whether they've had additional support needs at school or from social services. In the MCS, parents self-reported their own mental health over 7 sweeps from when the cohort member was aged 9 months to 17 years. And at age 17 in the Millennium Cohort study and also next steps, there are self-report questions on depression, anxiety, and in some cases more detailed specifications, and through adulthood and midlife, extensive self-reporting in the NCDS and BCS 70. So also, moving on, there are a number of mental health scales used across the cohorts in childhood. In the NCDS and BCS 70, the Rutter behaviour scales was administered successive times across childhood and completed by the cohort members' parents. The scales measure emotional and behavioural difficulties. In addition, in the NCDS at age 7 and 11, the cohort members' teachers completed the British Social Adjustment Guide, which contains 250 descriptors of behaviour, which are wide-ranging, and for example, some are grouped together based on emotional disturbance, for example, or social maladjustment. In the BCS 70, the Conners Hyperactivity Scale was administered at ages 10 and 16, completed by the mother, and a measure called the Child Development Scale was completed by teachers at age 10, which consisted of selected items from not only from the Rutter scale that I mentioned and the Conners Hyperactivity Scales, as well as the Swansea Assessment Battery. So it includes emotional behavioural difficulties, hyperactivity, and more school-related items. For example, did they pay attention in class? Did they truant from school? In next steps, the main mental health standard scale is the General Health Questionnaire 12, which measures psychological distress, and that was administered at ages 14 and 16, and also in the BCS 70 at age 16. In the MCS, the main mental health scale used throughout childhood and adolescence is the Strengths and Difficulties Questionnaire, which assesses 5 domains: emotional problems, peer problems, behavioural problems, hyperactivity, and pro-social behaviour. Also at age 14, the Mood and Feelings Questionnaire was completed by the cohort members in the MCS, and this is a unidimensional measure of depressive symptoms. There are a number of measures which were completed by different reporters, thus allowing for cross-reporter comparisons. For example, the Rutter Behaviour Scale completed by the parent and teacher at age 16 in the NCDS, And the strengths and difficulties questionnaire in the MCS reported by the teacher and parent at age 7 and 11. And also in the MCS, the SDQ was completed by the parent and the cohort member at age 17. In addition, scales were administered to the parent, measuring their own psychological distress when the cohort member were age 5 and 16 in the BCS 70, and throughout childhood in the MCS. Also at age 16 and 17 in the BCS 70 and MCS, these were administered parent and cohort member collecting information on their own mental health at that time. So in adulthood, the primary measure in both the NCDS and BCS 70 was the malaise inventory, which measures psychological distress, has been measured 4 times from age 23 to 50, and in the NCDS, in the BCS 70, 5 times from age 26 to 46, allowing for both within and across cohort comparisons. The NCDS, BCS 70, and General Health Questionnaire 12, again a measure of psychological distress in adulthood, and the SF36 was measured in midlife in the NCDS and BCS 70, which contains a mental health subsection consisting of 10 questions that assess general psychological well-being. In addition, during the biomedical sweep of the NCDS at age 44, the clinical interview schedule revised CSIR was administered, which assesses minor psychiatric disorder in the community, and it covers 9 areas such as fatigue, concentration, sleep problems, anxiety, phobias, panic, to name a few. So there are also measures of well-being. So we have the Warwick-Edinburgh Mental Wellbeing Scale, which was administered at age 50, 14 items of that in the NCDS, and also 14 items at age 42 and 46 in the BCS 70, and a shorter version, a 7-item version at age 17 in the MCS. And it covers most aspects of positive mental health, so positive thoughts and feelings. Also, life satisfaction has been administered a number of times across each cohort. And for the Millennium Cohort study, this is also completed by the parents about themselves from age 9 months to age 11. A variety of measures assessing self-esteem have been used. A 16-item measure in the BCS 70. 2 items in next steps asking about the cohort members' usefulness and how worthless they feel, and the shortened Rosenberg scale in the MCS measuring self-worth. Also, the quality of life scale in the NCDS at age 50 and 55, which was designed to measure quality of life in the 3rd age, and this covers 4 theoretical domains: control, autonomy, self-realization, and pleasure. Happiness has been asked in the MCS, and there are a variety of single items across all the cohorts on happiness or satisfaction measured in particular domains. So, for example, happiness or satisfaction at school, in your work, relationships, etc. There are also other related scales and measures which may be of interest. Personality has been measured in some of the cohorts, thus providing measures of emotional stability, openness to experience, for example. And in some cohorts, things like locus of control have been administered, and measures of self-efficacy across time. Self-harm has been measured in the most recent cohorts, and in the MCS, scales covering self-regulation, self-control, and also body image. So also, moving on to the 3 waves of fieldwork during the pandemic, we collected mental health data there. The main mental health scales relating to the specific cohorts that I've already mentioned, so for example, the malaise and the general health questionnaire were administered, plus items from the patient health questionnaire and generalized anxiety disorder at all waves. There was self-assessment questions on depression and anxiety in autumn 2020 and spring 2021. There's also well-being measures and other related content such as loneliness, social provision, self-harm, and optimism, for example. So also within the Centre for Longitudinal Studies, there is a substantive ongoing record linkage programme, excuse me, and health episode statistics, for example, are available for all 4 cohorts, including admitted patient care, critical care, A&E, and outpatient care. There's also Scottish medical records, which are available for the BCS 70, NCDS, and MCS, including inpatient, outpatient, birth, and neonatal records and prescribing information. And for the MCS, there is also health data available for Wales. So in order to identify areas of interest, you'll need to look at the World Health Organization International Statistics Classification, and this is a mouthful, of diseases and related health problems, the ICD-10, to interpret diagnostic codes for things like admitted patient care and outpatient care. And the mental health codes are available in Chapter 5 of the report, of the ICD-10 report, and this shows the high level and covers a wide range of mental health diagnosis, including behavioural, schizophrenia, mood disorders, neurotic stress-related disorders, personality disorders, and many more. And it goes down into a more refined level. So looking to the future, we're currently conducting fieldwork in 3 of our cohort studies and piloting the MCS. They've all been delayed by the pandemic, but we're pushing forward with those. In terms of mental health and related topics, all studies will repeat their main standard mental health measures and self-report for depression and anxiety. Life satisfaction will be collected in all. The Warwick Edinburgh Mental Wellbeing Scale in the MCS, NCDS and BCS 70. In addition, things like loneliness will be collected in all the cohorts. And there are new measures being piloted in the MCS, including shortened versions of the GRIT scale, positive childhood experiences, dysmorphic concern questionnaire, and the eating disorder examination questionnaire. So there's quite a lot. So how do you access the data and what resources are available to you? So the data is available via the UK dataservice.ac.uk. It's free to download for students, academics, government analysts, and the third sector. Each of the studies has a serial number as shown in the bottom right-hand corner of the slide there, and this will take you straight to the study, and the data sets have been grouped, usefully grouped into sort of main study administrative data, so it's much easier to find there what you're looking for. So as you've seen, there's a wide range of data available. The data goes through a process of classification based on sensitivity, disclosure, and is grouped into low, moderate, and the most sensitive and disclosive data. And most of the main survey data, such as the mental health report data I've talked about and scales, have been classified as low level of sensitivity and disclosure. And in this scenario, your application is authorised directly by the UK data service. You can go there and you can download it directly from there. Other data, which is under special licence, is moderately disclosive, and more sensitive data or disclosive, such as things like the linked administrative data I talked about, is available under secure access licence. And in order to access the secure data, you will need to attend a specialised training course. And I would advise, if you're interested in this, to look at the link on the CLS website. So there are lots of places you can search for more information. The CLS website has overviews of the studies and each of its sweeps, as well as documentation, technical information, and questionnaires. On the website, there are also links to other training resources, for example, recordings of the linked health administrative data in the cohort studies. And for each cohort, there are the following resources. So there's things like user guides for each suite. There's technical reports. There's questionnaires available when you download the data from the UKDS. You'll be given these things, but also this information is available, as I mentioned, on the CLS website. So as we've seen, a number of different mental health scales and standard instruments have been used in the cohorts, and a mental health harmonisation project led by CLS and commissioned by Closer produced some key output to help use the studies for cross-cohort comparisons. And indeed within, actually. These include a resource report on harmonising and measurement of the 4 CLS cohorts. We've discussed also the 1946 cohort, and also ALSPAC, a regional study who were born in 1991 in the Avon, Bristol area. There's an interactive tool of overlapping mental health items administered in these British cohorts, which is available in Excel, so you can investigate the items yourself for the work that you want to do. There's also a harmonised data set at age 10-11 available to download at the UKDS, covering 4 domains: emotional, peer problems, behavioural and attention hyperactivity problems. And if this isn't enough, there's a paper also published in Clinical Psychological Science investigating equating psychological distress scales in adulthood in the 1946, the 1958 and the 1970 cohorts. Also, it would be very remiss of me if I didn't also mention the catalogue of mental health measures, which, along with the mental health measures in our cohort studies that I've mentioned, also includes over 50 longitudinal studies covering a variety of mental health and wellbeing topics and standard instruments. And it's a highly searchable tool if you want to use our cohorts alongside other studies. And before I hand you over to Pravitha, just to say, on the CLS website, there is also a training and support page with links to key videos, specialist data, and also a plug for upcoming events. Our next is another themed webinar on social care, which is on the 20th of September. We also have an introduction to the BCS 70, which will probably be in October. And if you want to or know people who might like to help to get started using the CLS cohorts, there's a training session in November. So over to Pravitha.
Thanks, Vanessa. Can you hear me and see my slides?
Yeah, all good, Pravitha, but that's it. Yeah.
Brilliant. Thank you. I'm now going to just share some examples of the types of research you can do using these type of data. Just to really stress, these are examples. There have been hundreds of papers published with our cohorts related to mental health. I'll also share with you how you can look at what's already been published using the cohorts. And yeah, so before we start the actual specific examples, I just wanted to run through types of research questions you can answer using these data. And so to think about prevalence, and again, I don't think necessarily our cohorts are always, this cross-sectional prevalence studies, especially around mental health. However, they happen rarely, they're very expensive, and our cohorts being nationally representative also can inform prevalence studies. Longitudinal trajectories, and here the longitudinal nature of our cohorts really shines because you can't do longitudinal trajectories with cross-sectional prevalence studies. Measurement, so there's loads of questions, and Vanessa alluded to these things. We have different reporters, we have different measures, so there's questions around whether measures measure the same thing at different ages across different groups, so invariance, reporter differences that are specific to mental health. So as lots of you will know, we use parent measures, teacher measures, self-reported measures, and actually they don't correlate very highly, so it's interesting to think about what these different reporters are telling us about people's mental health, and things like scale equating, so processes around harmonizing measures and stuff. And because different measures have been used, these are quite interesting data resources from a measurement perspective as well. Transitions, again, the life course aspect allows you to study transitions over time. Risk and protective factors for poor mental health and good well-being. Really key thing that is very unique to the UK is cross-cohort differences. So as you've seen, there's a series of cohorts born in the last 70 years, and this provides a really, really unique resource to think about trends over time, but not just in prevalence, but also in things like trajectories, risk factors, and so on. And cross-cohort differences, could be over time, but also there's interesting questions around cross-cohort differences, for example, around place, right? So for example, there's a lot of birth cohorts, not historically, but more recently. So MCS, which is our most recent cohort born around 2000, has quite a lot of contemporary cohorts across the world, including in a wide range of countries. So there's not only interesting work you can do, generational differences, but also potentially cross-national differences. Inequality, so there's a big focus in CLS, and I'm sure outside as well, around who sort of struggles with their mental health, and if there are any systemic differences in this based on socioeconomic position, ethnicity, sex, gender, sexuality, and so on. Causes, consequences. Again, the longitudinal nature of our data sets really helps understand precursors, causal factors, and then subsequently lifetime consequences to a whole range of outcomes. And just to sort of also touch on, because we have healthcare linkage across most of the cohorts now, really interesting questions around healthcare access for mental health, who accesses healthcare, inequalities and who accesses healthcare, potentially predictors, correlates of the people's difficulties and access of healthcare, and potentially consequences from healthcare access as well, can all be studied in the linked cohort EHR data. And there's probably hundreds more questions I'm not covering here, but I just wanted to give a list of all the types of things we can do with the cohorts. And now I will just go on to use the next 15 minutes to provide some example studies to illustrate some of these potential questions. So prevalence. So high level, so this is just an example from MCS. For each example, I will say what cohort it is and provide the links. So these slides are going to be shared. You can always go look up the papers later. But in this particular case, MCS, when they were age 14, it had been a long time since there had been prevalence data for young people's mental health in Britain. The last prevalence study, like the official prevalence study, had been done in 2004. And there were lots of reports of increasing difficulties from all sorts of sources, but there wasn't national data. So MCS at that point had the ability to provide this unique and necessary public health evidence for the number of young people who were reporting high levels of depressive symptoms. And the most striking thing there was that the prevalence rates were quite high. So 1 in 4, so 24% of young 15-year-old girls and 1 in 10 boys. And we knew the question that would follow was, is this different from previous generations? And here we had a really nice scenario in which MCS and ALSPAC, which for mental health have much more similar measures across childhood and adolescence, had exactly the same measure at exactly the same age. And as you can see from this graph, just between those two generations, both in boys and girls, the prevalence had almost doubled in a very short span of 10 years. So again, thinking about the same question around mental health in adolescence, you can think about developmental changes. So this is just a very simple example of mental health and well-being at age 11 and at age 14. And what we see is when you think about total difficulties, mental health and life satisfaction and well-being, there isn't a noticeable gender gap at age 11, but by age 14, this really establishes. So you can see that girls have worse well-being and greater mental ill health at age 14, whereas at age 11, there's not this difference. So moving on to some older cohorts and cross-cohort stuff. So in this particular case, we have an example of adulthood trajectories. And as you can see, the many years of data, especially in NSHD, which is the cohort born in 1946, you really can get a full adulthood trajectory of symptoms in the same people over time. And again, in this particular case, there's a cross-cohort element as well, where we're looking at these symptoms across generations. And what we see is the most recent generation among these three generations, so the generation born in 1970, has higher symptoms from an earlier age. And the midlife peak, so as you can see, there's like a inverse U shape for psychological distress that is very well established, but that where the peak's happening seems to be getting younger. And then using the cohort sweeps, Dario and colleagues built on this work to look at what was happening during the COVID sweeps. So you have the same life course trajectories we already just saw, and then you have here the sort of what happened during COVID. And I suppose an interesting thing here is the sort of shock that COVID provided seems to have affected psychological distress in a way where that sort of lifetime peak, which you expect to start going down again, has a temporary rise. I mean, we don't know actually if it's temporary or not, but there's an increase at an unexpected place in the life course, and future data collections will allow us to see whether that was a COVID sort of blip that goes back, or whether this is like a fundamental change in the life course trajectory of distress for these generations. Moving on to an example on socioeconomic inequalities and MCS, just to sort of introduce the concept of socioeconomic inequalities in this presentation. So as you can see, at age 17 in MCS, we not only have distress measures, but we also measure self-harm and self-harm with suicidal intent. And this is a nice illustration of how the inequalities and patterns in different outcomes can vary. So you can see a classic gradient for high distress, a sort of fairly flat gradient for self-harm. So self-harm doesn't seem to be as socially patterned as distress and suicide attempts. And then for suicide attempts, there's like twice the rate of attempts in the poorest, young people from the poorest households compared to their richer counterparts. And then for this particular question that around sex and socioeconomic inequalities, Owen McElroy and colleagues just recently have published a cross-cohort paper where this was examined across 4 different generations. And as you can see, the gender inequality, which is the top bit here, hasn't changed across cohorts. So girls have worse mental health than boys across these generations, and that proportionate differential is the same. But for socioeconomic inequalities, there seems to be a widening, where for more recent cohorts, there's wider socioeconomic inequalities in mental health. So an example thinking about a particular inequalities at a particular life stage. So this is data using the Next Steps cohort, and Next Steps, which is the millennial generation, particularly faced a number of unique challenges as they entered the labour market. They entered the labour market at the start of the big recession, faced higher than ever university fees, student loan debt, and much more precarious working. So that the prevalence of sort of gig economy, non-secure contracts is much higher for this generation. So this is looking at labour market status and mental health at age 25 in Next Steps. This is work that Morag led on. And as you can see, being unemployed, a shift worker, or on a 0-hours contract were all associated with having worse mental health at age 25. And in this particular study, Morag also looked carefully at other intersections of inequalities like ethnicity. And so, yeah, just to highlight that we have really detailed data on lots of aspects of people's life, including, for example, labour market participation and the types of contracts people have. And this allows us to look at the intersection of different fields and different identities and mental health outcomes. Oops, it's not moving. Sorry. Okay. Consequences. So the older cohorts especially are really, really powerful in providing evidence around the longer term impacts of early life mental health. So Alyssa, who's the director of CLS, has a really seminal study in PANAS, which is called The Long Shadow Cast by Childhood Physical and Mental Health Problems, where you across a lot of different economic and other outcomes, there is long-term sort of adverse impact of childhood mental health difficulties, and this impact is greater for mental health problems in childhood compared to physical health problems in childhood, which is again an interesting, the sort of having all these different information allows us to make that sort of comparison. And then George Providus, who's the PI of 1970 and the 1958 cohorts at the moment, also has more recent work where we've looked at early life mental health with biomarkers in midlife and early mortality. So just again, really powerful data because of the long-term follow-up in looking at the long-term impacts of mental health. And again, with all of these things, we have the possibility of a cross-cohort angle. So this is work that was led by Ellen Thompson, where we looked at cross-cohort changes in the consequences of adolescent mental health on midlife outcomes. And so essentially, if you're thinking about this relationship, we're looking at cohort differences in it, and we find that the midlife consequences for more recent cohorts, so in this case BCS 70, seem to be greater, in the sense that the association between age 16 mental health and poorer outcomes is stronger in the more recent cohort. And this is despite the recent cohort also having greater prevalence of adolescent mental health symptoms. So not only do more people struggling with their mental health in adolescence, generation on generation, their consequences also seem to be getting worse. So just to touch very briefly on correlates, and this is just also a chance to show off this very fun infographic we made. But essentially, this was our attempt to really, across a range of risk factors, look at what is associated with both mental illness or ill health and well-being at age 11 in MCS. And this is a really detailed paper, but because we look at all sorts of types of correlates and also look at how much variance they explain, so you get that opportunity of thinking about what are the different things that matter and how much relative to each other for both mental health and well-being. But also conceptually is quite interesting, because as you can see from the infographic, the correlates of ill health and well-being are not necessarily always the same, which is interesting from sort of also theoretical perspectives on whether ill health and well-being are just two ends of the same spectrum or two slightly different but parallel things. So just to highlight both the possibility of vast richness in risk and protective factors, but also because we have multiple mental health outcomes, the possibilities around looking at differing risk and protective factors for different aspects of mental health. And we're going to end on this very, very recent paper where we looked at sexual violence in mid-adolescence and MCS as a risk factor, as a causal risk factor for mental health, but also in the context of the gender gap, because it's a very gendered risk factor. So 5 times, girls are 5 times more likely to experience these exposures in mid-adolescence. And what we find is between 14 and 17, girls and boys who experience this outcome who might have had similar mental health at age 14, and then the young people who experience sexual violence have much worse mental health at 17, trying to tease out sort of isolate the impact of sexual violence on mental health development at this age. And from thinking about policy and impact, we try to think about, assuming this effect is causal, what is the impact of eliminating this exposure using policy, societal changes, or however you would eliminate this exposure. And we see that it hypothetically could lead to between sort of 15 and 20% in the rates we see of distress, self-harm, and attempted suicide in adolescent girls, and between 4 and 11% in adolescent boys. So in terms, and again, because this is a national sample, what we can do is try and extrapolate back to the target population, which is young people born in the early 2000s in Britain. And by doing that, we're also able to say, based on these many young people born in these years, based on the national ONS stats, you could extrapolate these numbers to mean 91,000 fewer girls in the UK might have self-harmed at age 17 if they had not experienced sexual violence as adolescents. So I realized this was a whirlwind. It was meant to be. It was trying to be like, these are all the exciting types of things you can do. But as you can imagine, these data have been around for a long time. And we have a bibliography that is constantly maintained and updated, where you can check what has already been published using the cohorts. As you can see, you can filter by keywords, by study, dates, authors, journals, all sorts of things. And so, for example, if you use the keyword mental health and filter by MCS, or don't filter by studies, if you don't filter by study, you'll get the whole range. If you filter by any particular cohort, you should get, and obviously we can't guarantee this is super, like has everything. We try really hard that it to include everything, but it's definitely the best place to start if you have a question you want to answer in the cohorts and you want to look at what related things might have already been done using our data sets. And just before wrapping up, as Vanessa and Morag already mentioned, this is the first of sort of themed webinars we've held, and there's going to be many more, hopefully more also around mental health. And so as we're developing a more thematic sort of framework around our research, there will also be, the website will also have a mental health theme page soon. It's not there yet, so that's why I don't have a screenshot. So hopefully in a few months, there will be a place on the website where you can go and you should get all the resources we shared today, the harmonization reports, the variable lists, all of that stuff for mental health in one place on the website soon. And thank you.